Hi, my name is Dr. David Rubin. I'm from the University of Chicago. Welcome to this special program. On behalf of CME Outfitters, it's my pleasure to invite you and to welcome you to the program that we've put together for patients called Who's in Charge, You or Your Crohn's Disease? For the next hour, I'm really looking forward to a conversation with my very good friend, Dr. Bruce Sands from Mount Sinai Hospital in New York City. Dr. Sands and I will be discussing management of Crohn's disease and, very importantly, an update on new guidelines that have been published related to the management of Crohn's disease. We both feel that it's very important for patients to understand these guidelines and certainly to understand the advances that have occurred in managing Crohn's disease so that you can take charge of your Crohn's disease, or if you're a loved one who has a family member with Crohn's disease or someone that you care about, you'll understand how to support them. During this program, we want to encourage you to ask questions. This is a program that's streaming live through the CME Outfitters program, and you can send us questions by typing a question in the box under the presentation, or you can actually email questions@cmeoutfitters.com, or you can tweet your questions if you have a Twitter account, and you use the hashtag Take Charge of Crohn's, no spaces, and we'll be watching for those questions as they come through. Dr. Sands and I will be going through the entire program, and then we've left plenty of time at the end to try to address some of your questions, and we hope that you'll find enough information during this program to have an informed conversation with your healthcare team and the people who are managing your Crohn's disease when we're finished. I want to again say that I'm Dr. David Rubin. I'm very pleased to be doing this program with Dr. Sands. We wanted to start actually with a little history of Crohn's disease and a bit of ulcerative colitis. I'm actually the Joseph B. Kersner Professor of Medicine at the University of Chicago. The name of my professorship is named after Joseph Kersner, who worked at the University of Chicago his entire career focusing on inflammatory bowel disease and lived to be 102 years old. Dr. Kersner saw patients until he was 95 and came to the hospital every day until well after he was 100 years old. So it's really my honor to have his name as part of my professorship. But Dr. Sands has an even more distinguished title. He's the Dr. Burrell B. Crohn Professor of Medicine in the Dr. Henry Janowitz Division of Gastroenterology at the Mount Sinai School of Medicine. And I thought Dr. Sands could tell us a little bit about Burrell Crohn and about your professorship.
Right. Burrell Crohn was a legend, certainly at Mount Sinai, but in the world of gastroenterology, who described with his co-authors Ginsberg and Oppenheimer the first case series of what we now call Crohn's disease, but they didn't call it that. They called it regional ileitis. Truthfully, there were a few other groups across Europe that may have described what we now call Crohn's disease before that, but the recognition came to this group. And he also was long-lived. He lived late into his 90s.
Yeah, so I think the doctors who study inflammatory bowel disease live a long life, and hopefully that'll
David.
be us too. So in this picture here, this is Burrell Crohn, right?
Yes.
And is he flanked? This is Leon Ginsberg, I believe, or is that Oppenheimer?
I'm embarrassed to say that I can never tell them apart, but Janowitz, who our division is named after, is right there.
Yeah, so this is a very famous picture of one of the first grants that was given for research related to IBD, I believe. So we're really happy to have you with us tonight, Bruce, and obviously you carry on a wonderful legacy at Mount Sinai. We're going to talk about the new guidelines in Crohn's disease and try to help patients and their family members understand what we know about Crohn's disease and some of the significant advances that have occurred. And we're very pleased to share with the audience and to make sure people know that we've made some great progress. We always remember, though, that there's more to do. Ultimately, of course, we want to understand the cause and cure these conditions. In the meantime, however, we want to emphasize that there have been some tremendous advances in medical therapy and, very importantly, understanding how to control the disease and provide high quality of life. Let's review briefly, though, what Crohn's disease is. Crohn's disease is a condition that is characterized by chronic inflammation of the intestinal tract. By chronic, we mean that it lasts a long time and in most cases diagnosed at a younger age and then may last a lifetime. There are some people who are not diagnosed with Crohn's disease until they're a little bit older. Technically, Crohn's disease can involve any part of the GI tract, but most commonly we find it at the end of the small intestine in the area called the ileum, where it connects to the large intestine. The cause remains unknown. There are lots of different theories about this, but in general we describe it as an overactive immune response. Remember that the immune system of your intestine exists to help you distinguish from things that might harm you from those that you need for nutrition and health. And what we've come to appreciate is that in Crohn's disease, the immune system of the intestine is overactive or continuously stimulated, or both. And that's what leads to progression of the disease and causes symptoms and may result in some complications. We characterize Crohn's disease as either relapsing and remitting, meaning that sometimes it's very active and sometimes it shuts off and it's quiet. And in some cases, we've come to realize that the Crohn's disease inflammation may progress, causing a complication over time, like a bowel obstruction or penetration to other organs within the body. There have been some new treatments developed, and we'll be talking about those tonight. Now, one of the features of Crohn's disease is the inflammation causes thickening of the bowel. In this particular slide, you can see on the left side a normal segment of small intestine, and on the right side what it looks like when it's inflamed with Crohn's disease. This is distinct from what we see in ulcerative colitis, which tends to be more superficial inflammation. In Crohn's disease, it can involve the entire thickness of the intestine and then involve other organs or cause an obstruction of the intestine, which is an important feature of Crohn's disease. About 15 to 20% of people with Crohn's disease have a feature of their disease called perianal Crohn's disease. This is focused on the very bottom of the large intestine, an area called the anus, which is below the rectum. And in this situation, patients develop inflammation that may bore through the wall of the anal canal or the very bottom of the rectum and cause a track or a connection from the inside of the bowel to the tissue around it and ultimately to the skin. Those abnormal tracks or connections are called fistulas. And in the cartoons, you see the difference between a simple fistula, where there's a single track here that would be draining from the outside of from the inside to the outside of the body. And closer to Dr. Sands, you can see what we would call complex fistulas, where there's more than one, or they make turns within the tissue around it. As you might imagine, perianal Crohn's disease can be very uncomfortable, can have a poor quality of life associated with it, and in our management strategies, we focus on patients who have these conditions and treat them very aggressively to make sure we try to control the inflammation. This is also a condition of Crohn's disease that sometimes needs help from our colorectal surgery colleagues, either to clean up the draining areas or to help us heal those areas. And Dr. Sands will talk about some of the treatments we use for this in the future part of this presentation. Now, what we're going to be talking about and what stimulated us to do this presentation today is that in the last year, there was a new guideline for the management of Crohn's disease that Dr. Sands was one of the important authors on for the American College of Gastroenterology. And then there was also a new guideline related to ulcerative colitis, also for the American College of Gastroenterology. Our other society, the American Gastroenterological Association, also came up with some new guidelines and care pathways. So there have been so many advances in our field that we felt it was really important not just to educate our colleagues on these diseases, but also to teach patients and their family about some of these advances. So what are clinical practice guidelines? Well, guidelines are designed by experts in the field to summarize the available best evidence and opinions about managing a condition. And in this case, we're talking about Crohn's disease. The recommendations are meant to reflect the best available evidence, that means scientific studies that show specific outcomes, and to provide clinicians with recommendations and suggestions about how to best manage. They're not always set in stone, and they're meant to guide us. They don't necessarily mean that it's the right treatment for everybody, but they're very important. So guidelines, when they come out, often try to move the field forward, to acknowledge advances we've made, to identify areas where there's still some controversy or things we don't know, and to help us move along and take better care of our patients. When we look at guidelines, they're based on different levels of scientific evidence, and we have a grading scale for how strong the evidence is. They start with things that are just based on good practice or the opinions of experts without necessarily the strongest level of evidence. There's some value in that. Certainly master clinicians and people who take care of lots of patients have some ideas about what might be good. But beyond that, we look to more scientific evidence. This may start with reports of cases, of situations with specific outcomes, and then stronger levels of evidence include what we call randomized clinical trials, where patients are randomized to one treatment strategy or another, and we look at specific outcomes in terms of how they do. And ultimately, the strongest level of evidence is when we have multiple randomized trials, all with similar findings that we can combine into knowing that what is seen and what has been done is likely the best approach. So guidelines combine all these different levels of evidence to come up with strengths of different types of recommendations for practitioners. What we're trying to do here now is to summarize them for our patients. Now, what we've learned through a Twitter poll and, of course, through talking to our own patients in practice is that very often patients don't know that there are guidelines, or certainly don't know that there have been new guidelines published. So that's partly why we developed this program tonight. And we've actually interviewed some real patients and asked them to comment on whether or not they knew there were guidelines. So let's listen to what a couple patients had to say.
Of IBD patients are very confused, and there's a lot of misinformation on the internet.
I don't think that patients are aware of clinical guidelines very much at all.
So you can see from these patient examples that many patients are not aware of what the guidelines are. Now, we also recognize that there are limits to these guidelines. You might think or hope that all of the people who take care of patients are aware of the latest guidelines, but that's not always the case. So we have other efforts that we make, including some of our national meetings and in other methods to try and make sure our colleagues are up to date on some of these guidelines. They also have a tendency to become out of date quickly. It takes a long time to get a guideline through all the different review panels and appropriate publication channels, and then there's new evidence. So as soon as a new guideline comes out, it may already have some pieces of it that need to be updated. It's a little bit like throwing a pass downfield and expecting the wide receiver to be where you need it when the ball comes down. So we try to think ahead so that we can move the field forward and it's not going to be out of date as soon as it's published. The other challenge to guidelines, and I want to emphasize this, is that it doesn't always apply to everybody. So we recognize that Crohn's disease and ulcerative colitis can be very heterogeneous. There are lots of different types of diseases within these diseases that we call Crohn's and colitis, and therefore individual patients may need something that's a little different than what the guidelines suggest. And lastly, despite our efforts, the people who pay for some of our expensive therapies may not always agree or even be aware of some of our newer guidelines and the levels of evidence, maybe because the therapy is so expensive or maybe because they just don't make that a priority for them. So there are lots of limitations for us to realize and think about with the guidelines. So Dr. Sands, if you could spend a moment now and take us through some of the thoughts about these guidelines. Tell us a little bit about the ACG guidelines that you were part of and how we should be thinking about this.
Right. As you said, the creation of guidelines is a very rigorous process. It takes a lot of thought, a lot of effort, a lot of delving into the literature and sifting through the evidence. So it begins with a committee of people who are assigned to do this. They look at all this evidence and they grade it and then come out with statements of what should be more or less a standard of care. So this was done it took more than a year actually to create the ACG guidelines, the American College of Gastroenterology guidelines for Crohn's disease. And you were spearheading the ulcerative colitis guidelines at the same time, which we're not talking about here. The AGA has also updated their guidelines. They had a more focused guideline related to the use of thiopurines, methotrexate, and anti-TNF biologic drugs in the treatment of Crohn's disease.
So why have two different sets of guidelines? Wouldn't they all be the same if we're using the same evidence?
Well, mostly they do overlap, but some of the approaches can vary depending on how the experts may think of it. And as you also pointed out before, some of this, because we don't have evidence for everything in the literature, some of it has to be content provided by expert opinion, and that's where they can differ.
So what's new in the guidelines that came out last year? Tell us some of the things that our patients should know about or that we should be looking forward to.
Yeah. Well, historically, we have tended to treat patients in what was called a step-up approach. We would start with a base of treatment, which was perceived to be maybe a very safe, but maybe not the most effective treatment. And then if the patient didn't respond, we would ratchet it up to the next level of treatment, sort of this pyramid approach. We have recognized over time that that is probably not the most effective way of treating patients with Crohn's disease, because while we're trying to get it right through trial and error, often the disease is progressing. So there's an urgency to treating the disease very effectively. And therefore, we want to take into account the patient's prognosis. We want to try to predict what the course of the disease will be like so that we match the treatment to the appropriate level of prognosis for a given patient. So we're thinking more along the lines of how do we tailor the treatment for the patient. And that's where the second new principle comes in, which is this treat to target approach. To treat to target, and I'll explain this a little bit more in a moment, is really to keep in mind that we're trying to achieve a number of important goals in treating Crohn's disease, and we don't want to lose sight of those goals, and we want to make sure that both the patient and the physician know what the appropriate goals are and to try to hit those goals. We'll talk about that more in a moment. Also, the guidelines had to incorporate newer treatments beyond the traditional conventional therapies, which included steroids and immune modulating medications like azathioprine or mercaptopurine. And these certainly include the anti-tumor necrosis factor antibodies, which were the first biologics we had, and we've been using them for more than 20 years. But in the last 5 or 6 years, we've had the addition of vedolizumab and ustekinumab, so those had to be incorporated. And then finally, yet another means of tailoring the treatment to an individual, which is the approach of therapeutic drug monitoring. So we can, in some cases, measure the levels of drugs and adjust the dose of the drug to make it appropriate for the individual to achieve the best responses.
So you mentioned this treat to target. Can you just explain a little bit more? Because I think that's one of the most significant advances to thinking about how to move people through different treatments when they're being managed with Crohn's disease.
Yes, I mean, you could think of the treat to target approach as a cyclical kind of repetitive process. It isn't just something that you do once. It's something that you have to keep in mind continuously as you go through treatment. And basically, we have defined in Crohn's disease what appropriate targets are. We'll talk about those in a moment. We'll begin a treatment, but we don't want to just assume that the treatment is going to work. We want to assess whether the target has been achieved. And if it hasn't been within a certain period of time, then we want to adjust treatment appropriately and then reassess the target to see if we hit the target at that point. Once we do hit the target, that's not the end either, because patients over time can lose response and deviate from that target. And so we have to monitor to make sure that the target is maintained. And if it isn't, then the process starts over again.
So some of the patients who are watching this program may say, isn't that what we've always done? My doctor recommends a therapy and I try it, and if I feel better, I must be where I need to be. And if I don't feel better, I call and I complain or tell them I'm not feeling well. So how is this different? What does this do that's different than that?
This is really a much more proactive approach. We're really defining the target not simply as you're feeling better, but that we actually know that the disease is under control. And that means assessing the status of the inflammation in the bowel, not just how you feel, because those two things don't always match in Crohn's disease.
So how often is it that patients feel okay, but they're still inflamed?
It can be as much as 1/3 of the time. It's surprisingly high.
And what would be the consequence of that? I mean, what happens if that is going on?
If inflammation goes on in an unchecked fashion and it can be smoldering beneath the surface and you may not be aware of it, then gradually there is progressive damage to the bowel. That can't be reversed easily with medication. This might include stricture formation, or meaning a narrowing of scar tissue, or fistulas may form, meaning the disease process penetrates through the bowel and outside the bowel, those things are very hard to treat with medications and often will require surgery. They're just not reversible otherwise.
So, Dr. Sands, you're a clinician, you take care of a lot of patients. Take us through how you explain the goals of managing Crohn's to a new patient.
Right. So when I talk to a patient about what I'm expecting, I want to clarify for them what their current status of their disease is. How much activity is there? How severe is their disease? And those are not exactly the same thing. Activity is sort of what I'm seeing at the moment for their inflammation and their symptoms. Severity is more about their trajectory of their disease. How rapidly progressing is their disease? And that is not that easily defined for everyone, but often can be predicted based on a variety of factors. One thing that patients ought to know for themselves is how much bowel is involved. Is it just a tiny little segment of small bowel, or are we talking about many inches or even feet of bowel? And that has implications for if I needed surgery for you, or if you needed surgery, what is the risk of that surgery? The next thing that is an important goal is to get the disease under control and do it fast. Time is marching on. As time progresses, there's more and more bowel damage. We're not talking about minutes, we're really talking about weeks and months that may make a difference, however. Plus, you may be feeling miserable, and we want you to feel well and to be functioning well. So we want remission of symptoms quickly, and we also don't want to stop there. As I said, we want to heal the bowel and improve it. Once we get you there, the goal of management is to prevent relapse, and that's more about maintenance of the disease. And then finally, we want to monitor you and do whatever we can to prevent complications of not only the disease, but also of the medications that we're treating you with, because all medications have potentially some safety issues that have to be monitored for. So we want to prevent complications of the disease or the treatment, which may include infections from both the disease or the drugs, in some cases, prevent you from being hospitalized. Certainly we want to prevent surgery if we can, although surgery is sometimes very helpful. And ultimately, we certainly don't want our patients to be disabled by these conditions.
And the emerging understanding of managing Crohn's disease has emphasized that when you are able to control the inflammation beyond just making people feel better, you can prevent some of these outcomes. And that's where the treat to target strategy has become more understood, and it's certainly the goal we want for our patients.
That's
so
right.
When we talk about remission, it's how they feel, but we want it to last. And in order to have it last, we need to have control of the inflammatory problem.
Correct.
Let's hear again what some patients had to say about what remission means to her.
Remission looks like being able to live my life fully without suffering from IBD, without putting things aside. I have activities that I can't participate in just from the symptoms and the pain from IBD. I have had to sit out from things, had to leave work early because of my symptoms. So remission to me is not having to do things like that where my life is impacted in a negative way.
So we certainly appreciate that many patients who've had Crohn's disease have had it negatively affect their life or impact their ability to function socially or at school or at work or to take care of family members. And one of the things that we really want to emphasize is that if we are able to control the inflammation, we're also able to give patients something that they definitely deserve, which is some knowledge of certainty. They're going to be less likely to have a relapse or have these unexpected episodes where they're sick if we know that their disease is under better control. And I try to emphasize that too as part of our goal as we work through these things with patients.
Yes.
So I just want to remind everyone, we actually have a whole bunch of questions that came in already, so that's wonderful. But if you'd still like to send us one, you can either type a question in the box under the presentation if you're watching us right now. You can also email questions@cmeoutfitters.com, or you can tweet using a hashtag #TakeChargeOfCrohn's. No spaces and no apostrophe. Okay, so let's keep moving on. We have some more things to talk about. So we already mentioned briefly in your goals, Bruce, that symptoms and control of inflammation are both important. So let's get into this a little bit more and think about some of what we should know. So take us through why symptomatic remission is not enough and how patients should be explaining this, and maybe also what they should be asking their care team to better get control of the situation.
Right. So we said this in brief already, but I think I estimated 30% of patients in symptomatic remission still have persistent inflammation, but some estimates actually show it to be much higher. It may be as high as 75%. It probably depends a little bit on how we're defining inflammation. So that tells you could feel really well or relatively well, and yet the disease is still active on the inside. The disease process is not ultimately controlled. And we know that when people have ongoing inflammation in the bowel, there is a much higher risk that they're going to have symptomatic relapse over the coming year or two. So the implication, conversely, is that if you can control the inflammation, you may prevent that relapse. When we talk about mucosal healing, we're talking about healing of the inflammation of the bowel lining. This is typically what we see if we're looking in by colonoscopy and we're evaluating the disease that way. But we can also evaluate through imaging of the abdomen, such as with a CAT scan or an MRI. But that's really what we're looking for. It is a measure of the activity of the disease that is most directly involved with the disease process. And we now have evidence that in real studies that show that if you can achieve mucosal healing, that actually lowers the risk for relapse and surgery, and that's the goal.
So I'm sure that people listening to this who are symptomatic are wondering about how much inflammation there is. And those who may be feeling okay might now be worried that they're inflamed. So you mentioned CT scan or MRI, colonoscopy. Are there other things that we can do to know whether someone's inflamed that might not be as expensive or invasive?
There certainly are. None of them are totally perfect, but as a cheaper, easier way of getting at whether the inflammation is controlled, we can measure things in the blood. For example, we can measure C-reactive protein. We can measure something called ESR, or erythrocyte sedimentation rate. Those things are not perfect. They are not always elevated in people who have real activity of their inflammation. And in fact, maybe 20 or 25% of patients, people in general, don't make C-reactive protein and can't express it at all as a marker. But more directly, we can measure things in the stool. And I know patients don't like giving stool specimens. Who does? But there are things that we can measure, such as calprotectin in the stool, which would be a much more direct measure of inflammation in the bowel. Again, none of these things are perfect, but they're reasonable surrogates.
Okay, so our patients and their family members should be asking about ways to know if they're inflamed and to monitor that over time. What about the opposite, though? What about patients who are symptomatic and then they had these tests all done and there's no inflammation? Does that happen? And in your experience, how often, and what might be the cause of their symptoms then?
That certainly does happen, that people have symptoms and they have no evidence of inflammation either on these blood or stool markers, and sometimes even when you look in by colonoscopy or you do a scan, there's no inflammation. And there could be a variety of explanations for those patients who have symptoms that haven't gone away even though everything is demonstrably healed up. And that includes everything from kind of residual irritability of the bowel and symptoms from that, even after the inflammation, and that's a pretty common occurrence. It could be if you've had surgery that you are not absorbing the bile salts that normally would be absorbed by the last part of the small bowel that may have been removed, and that can cause some diarrhea, cramping, and irritability. And we also know that if you have any added anxiety or depression, that will tend to magnify even minor abdominal symptoms and make you feel more symptomatic. So it's important to get that treated too if that is a problem.
Right. So the point is careful investigation and considering other things that you've nicely outlined. One of the challenges in Crohn's disease, and I'm sure people can relate, is pain. And pain can be from different causes. Of course, we worry if there's an abscess or an infection, or if there's a bowel obstruction, or if there's inflammation that's irritating the organ around it or the lining of the abdominal cavity. But then there's lots of other things that we should be carefully investigating, whether it's a side effect of medicines whether it's a kidney stone. It requires a careful evaluation and directed therapy. So we've talked about a lot of different things. Let's move on now and get to the treatment part, which I know lots of people are waiting for, and I'm sure we'll have questions about. So let's think a little bit about treatments for Crohn's disease. And I want to start by asking you something. I started off the program by mentioning that we're looking for a cure for Crohn's, or maybe more accurately, cures for Crohn's. In the meantime, why do we treat with therapies that are directed at our immune system? Why has that been the target of our therapies that seem to work?
Well, we've known for a long time, really for decades now, that the immune system is, for reasons that are only partially understood, overly active in the bowel. And while that would be appropriate if you had a bowel infection, that's the right thing to happen, the immune system should turn on. There's no demonstrated infection of the bowel and inflammatory bowel disease, and yet this inflammatory process is ongoing. And therefore, really, virtually all the medications that we have are directed at either turning down the inflammation, affecting the inflammation process, or turning down, adjusting downward the immune system. And that clearly is beneficial as an approach.
So let's move on now and review some of the treatments for Crohn's disease. Obviously, we could probably talk for an hour about each one of these bullet points.
But we won't.
But we won't be able to. But perhaps you can just give us an overview. And we have used the trade names for some of the drugs just so that our patients who are participating here understand what we're talking about. So can you just take us through the different classes of therapy briefly?
Right. So, you see here, everything above the biologics would be called more or less conventional therapies. These are older medications. These are all conventional medications in the sense that they're either pills, usually they're pills, actually, in most cases here. We start at the top with sulfasalazine, which is a very old treatment that dates back to the 1930s or 20s. And is really modestly effective for Crohn's disease, particularly of the large bowel, but it isn't very widely used and not very effective either. Steroids certainly have been used for many decades, and they are still helpful for some, but they do have some safety issues, as we all know, and they should never be used for long-term treatment of Crohn's disease. We have a more modern form of steroid called budesonide, which really works on the inner lining of the bowel, and very little of it is absorbed into the system, so the steroid side effects tend to be lower, so that was some progress. Antibiotics are sometimes used in Crohn's disease, especially in perianal disease or fistulas, or may also be used after a surgical resection of small bowel to try to prevent relapse or for different infections. And in children, it's not uncommon to use elemental diet, a more restricted form of a liquid diet, and for reasons that are also not perfectly well understood, that can decrease the inflammation. But the problem is it's effective when you use the medication, but once you stop using, not the medication in this case, but the elemental diet, when you go off that diet and you resume a conventional diet, the disease often relapses. Then we get what are called the immune modulators, and this would include the thiopurines, which include azathioprine and 6-mercaptopurine. These are pills. They have mild immune suppressing effects, and therefore they do have some side effects. Methotrexate, which is used in Crohn's disease primarily as an injection under the skin, but may at times also be used as a pill, taken just once a week. And then we get to the biologics, and these are newer medications in the last 20 years. In the case of the anti-TNF therapies, these would be Remicade, the first of them, and then biosimilars of Remicade, such as Inflectra and Renflexis. There's Humira, which is adalimumab, and Cimzia, which is certolizumab pegol. And we make our careers by pronouncing these things, and it's often easier for patients to remember the trade names, of course. Newer biologics would be the anti-integrin therapy called Entyvio, or generically would be vedolizumab. We do not use any more Tysabri or natalizumab, even though it is technically approved for Crohn's disease. It has one very serious potential adverse effect. And finally, we have anti-interleukin 12 and interleukin 23 antibody called Stelara, or ustekinumab. And finally, we shouldn't forget that in some cases, surgery is a wonderful option actually for patients with Crohn's disease.
So thank you for that overview. People are often confused or nervous about the term biologics. So I thought it would be helpful if we actually spent a minute explaining to the audience what a biologic is and what that terminology means so that we demystify it.
Yeah, so while the conventional therapies that I mentioned were at the top of the last slide are really chemical compounds, biologic therapies are different because they're actually made of proteins, not just chemical compounds that you can manufacture. These are not manufactured in the conventional sense. They're actually produced by living cells, and they're proteins. And the way most of them work is that all of these in this case are antibodies. Of course, your own body produces antibodies as a way of fighting off infection. The way they do this is these are kind of Y-shaped molecules, and the two tips of the Y very specifically bind to one kind of substance and help clear it out of the body. So in the case of infliximab, as an example, that's an anti-TNF antibody, and all it will do is bind to TNF and only TNF and help clear it out of the body.
So why can't they be taken as pills?
Well, if you took a biologic as a pill, our bodies are designed to break down and absorb proteins. Meats and other protein sources in our diet are digested, and you would end up digesting this very expensive medication, and it probably would not be effective for you in that way.
Yeah, that's the challenge. And just to drive home the point you made, when you use the term biologic, it refers to these antibody-type therapies. There's 3 different classes of biologics for Crohn's disease and for ulcerative colitis. And it's important to recognize that they're not all the same. They have different targets, they have different effectiveness, and they have different safety and different labeling. So it's important to keep that in mind when we go through some of this. So I'm going to go through a couple of the general principles of Crohn's. I'll do this part and then we'll hand it off. But the first point of managing somebody with Crohn's disease is to start with symptom resolution, make them feel better. We recognize, of course, that you want to feel better, and that's directly related to quality of life. The second part, as we've already talked about today, has been trying to get the bowel healed or look for objective measures that we've turned off the inflammation. That can be looking at all the different tests that Dr. Sands mentioned, or doing a scope or a scan. In children, it may involve making sure they restore their growth and development, which is very important. And we know when inflammation's turned off, kids will grow fast and they'll catch up, but it's a very important point. Then we look at customized treatment strategies, making sure that we're looking carefully at where the disease is located, how it behaves, and we recognize there's so many different types of Crohn's disease that often our treatment strategies need to be individualized and thought about in different ways. We choose our induction therapy not just on how sick the patient is, but on some of those risk factors related to their prognosis or likelihood that they might need a surgery or a recurrent surgery or have other complications. So we make decisions about treatments based on what we know about the disease location, its activity, and the prognosis. And then once we've successfully identified and used a therapy to induce remission, we have to identify a maintenance therapy. Because this is a chronic condition that can relapse or can progress, we want to make sure we choose a therapy that is effective for preventing the progression or preventing the relapse and is safe and tolerable over the time that we need it. It's a common question, am I going to be on this therapy the rest of my life? And the answer is most likely not. That's not what we're trying to do. And of course, we're making advances in the field. I've been telling patients for years that every couple years we have a major shift in our available options and the way we think about using therapies. So let's focus on getting you well and keeping you well now and define short time horizons. Finishing school, getting to your first job, getting married, having children, whatever those different goals are for you, we want to help get you to, and we keep reevaluating over time. And then very importantly, as Dr. Sands mentioned in the beginning, we want to make sure we continue to monitor. Recognizing that our therapies do work well in many patients, they also stop working in some patients. The natural tendency of any chronic condition is to drift away from control. It happens. Sometimes it happens also because we think the body is just trying to find a new inflammatory pathway. It is, after all, there to try and protect us, and the inflammation is the body's way of trying to protect us, or thinks that's what it's doing. So it's really remarkable that it develops redundancy and has new pathways. That's one of the reasons why we sometimes have to change treatments. And then lastly, and we'll come back to this, is the idea of prevention. Dr. Sands mentioned to you how we want to focus on avoiding complications. Vaccine preventable illnesses is important, monitoring the disease is important, and making sure you have a strategy to stay well once you're on your therapies. So that would include thinking about going to see your physician or your healthcare team or your advanced practice provider when you're feeling well. That's the opportunity to talk about all these other things as opposed to only having your doctor's visits or your nurse practitioner visits when you're not feeling well. We want to be able to have the time to review advances in the field and to discuss different ways to keep you healthy. So those are the general principles, and now I'm going to hand it back over to Dr. Sands to take us through some specific examples of how to apply the therapies.
Right. Well, so what was different in the ACG recommendations and the guidelines that were revised in 2018 was this notion of risk stratification. So for the patients who have lower risk Crohn's disease, meaning less likely to progress over time, are more on the mild to moderate side. There are a number of approaches which might involve simply treating diarrhea with antidiarrheal medications to make you feel better. Some of these are over-the-counter medications. There could be dietary modifications that may make you feel better as well. That usually has to be defined individually, really, because we can't necessarily predict which types of dietary items are going to make you feel poorly, but you probably can. But more importantly, if we are not treating the inflammation process because it's very indolent or very mild, we do still have to make sure that we monitor you carefully for disease progression. So we can't forget about that part of it. It's not just about treatment, it's about monitoring. And then if people have sort of mild, non-progressive disease, we might use sulfasalazine, which I mentioned, a very simple and safe medication. We might use a course of budesonide, this safer variety of steroid, for a limited period of time in most cases.
So the point here is if you think you have mild disease or you're told you have mild disease, whatever treatment strategy you decide on with your team, make sure that you're monitoring to know that the disease is under control.
Exactly.
And then let's talk about moderate to severe Crohn's disease, where there are lots of other options to consider.
Right. We have a lot of options, many more than we did even just a few years ago. And when we talk about moderate to severe Crohn's disease, again, we're talking about people who have a more serious prognosis, people who have the potential to progress to more complicated disease, narrowing strictures, fistulas, who are more symptomatic overall and just need more effective medications. That might include oral steroids for short-term use, but really not for long-term use because of their side effects. For those patients who are on steroids, it was still a recommendation to use potentially thiopurine medications like azathioprine or mercaptopurine, although we wouldn't use these medications to get the disease quickly under control. They may be effective in getting patients off of steroids and as maintenance therapies. Methotrexate in the same way may be effective for maintenance of remission and for steroid sparing, getting patients off of steroids. Thiopurines, again, for maintenance of remission, just like methotrexate. So those are the older approaches, and then the newer medications, the biologics, we have the latitude to use anti-TNFs to induce control of the disease, get it under control quickly, get patients off of steroids. We might use it for patients who have not responded to azathioprine or 6-mercaptopurine or methotrexate. We'll use it as maintenance medication as well. The other newer biologics, which would include vedolizumab and ustekinumab, can also be used for induction and maintenance of remission. And then there was one last recommendation, which is based on pretty good evidence that infliximab is more effective in combination with thiopurines than either single drug alone. And so that would be a very common and recommended practice.
So I can imagine this being quite overwhelming for our patients and their family members. How does the physician or the advanced practice nurse choose the therapy for the patient? What are some of the factors that go into making that decision? Or is it that people just work their way through one treatment after another?
You know, it is a complicated process, and it requires discussion and really a careful understanding of what the exact situation, and factors such as your age may go into it, the location of your disease and the severity of the disease, whether you have fistulas where some drugs may be more effective than others. And so it does require a lot of judgment and discussion with you. What are your values? What are your goals? And what are your concerns? And taking all that into account.
Yeah. And I think that the treat to target strategy that you explained so nicely helps us understand that whatever therapy we start in any situation, knowing that it's working and then moving on if it's not, is a helpful algorithm.
And sometimes adjusting treatment is also appropriate, because we may start at one dose with a medication and find you need a higher dose of the medication. Absolutely. Or more frequent dosing, and that may be just all that you need, not a complete change.
And one of the things that's influenced our choices of therapies has been the understanding of safety, both short-term and longer-term. And we have this pyramid of safety here that maybe you can explain a bit to us.
Yeah, the notion here is that the things at the bottom are the things with the greatest level of concern for side effects. And really at the bottom, boxed in red appropriately, are the steroids. While we do use steroids, and they are still helpful and sometimes necessary, as we've said repeatedly tonight, we don't want to be using these chronically. And these are not long-term treatments, and we know that there's an increased risk of infections and even an increased risk of mortality with long-term use of steroids. All the other things have acceptable long-term use. That includes at the bottom thiopurines and anti-TNFs in combination, but there are some concerns of infection and some rare kind of low risk of lymphoma, for example. Thiopurines and tofacitinib, which is really not used in the treatment of Crohn's disease but is used in ulcerative colitis, have a little bit less in the way of risk, so we're talking about one individual therapy. If you use single therapy of anti-TNFs, that is probably safer but not always as effective as combination therapy with thiopurines. And then finally, the newer biologics probably have the best safety profile, and these are vedolizumab and ustekinumab, which really don't seem to have increased risks of infections or of cancers.
And the reason for that, we think, is because of the way they target primarily where the inflammation is, and they don't affect the rest of the body in the same way.
That's right.
So those have certainly been some nice options that have become available. So one of the next issues, and we've mentioned this a couple times, has just been once the patient's in remission, the importance of monitoring. As much as you're relieved that you're feeling well and maybe you've been told your inflammation is shut off, we have to recognize the importance of ongoing monitoring, both to know if the disease is starting to relapse, as well as to, of course, keep an eye on how the therapies are working. And we know that things change over time. Bruce, you've already nicely mentioned the stool tests and the blood tests. So we'll move on, except to remind people that the purpose of maintenance therapy is to prevent relapse after you're already in remission. So if you stop the maintenance therapy, you might feel well for a little bit because you're in remission. But the natural tendency of a chronic condition will be that it will relapse. So we're always trying to figure out what's the least amount of medicine we need to keep someone well and to not put them at risk of disease progression or other complications. So what do patients with IBD say about understanding monitoring? We actually asked them, and we have an example here from Wendy.
I call and I am having any type of symptoms, she will order labs, and I know that she is looking for specific markers. I never have discussions with her about what the markers are specifically that she is looking for. I wish that I did have a better idea of what it is in the labs that she is trying to get.
So hopefully now we've laid out for you the importance of some of these tests, and it might be helpful for you the next time you're seeing your team to know why they're ordering certain tests. Is this to monitor your therapy, or is this to monitor your disease, or both? And what are they being used for? So the next brief point that we're going to talk about is just the last issue, which is you're finally on a therapy, it seems to be working, you're doing everything that you're supposed to do, and now the treatment has stopped working. So Bruce, just briefly, tell us why therapies stop working. It's a very frustrating problem for all of us.
Yeah, what an awful feeling. You're feeling well, and then all of a sudden you're not feeling well, and you're still taking your medications, which, by the way, is maybe the first question that your doctor will ask you, because as Dr. Rubin pointed out, one of the main reasons that people may flare is because they simply stop the medication because they're feeling well and don't understand that they have to keep taking medication. But assuming that's not the case, it's not your fault. The body will find ways of manifesting inflammation through new pathways that aren't addressed by the medication that you're taking. That's one explanation. It could be that you've developed an infection on top of the Crohn's, that you have some bowel infection that you've picked up somewhere, and that does happen. Unfortunately, that sometimes not only causes symptoms at the time of the infection, it can also trigger a bona fide flare of the Crohn's disease. And then for biological therapies, they're wonderful therapies, but one of the issues is because you're putting in a foreign substance of a protein into your body, your immune system actually has the potential to react to them and form your own antibodies, just like you react to a vaccination. And that then makes it have low levels of the drug in your blood because it's being cleared out quickly and you can't respond to the drug anymore. The last one, if you stop taking the medication, then obviously we do understand the reason for losing response.
Well, we've certainly learned about some ways to minimize this. One of the ways to prevent loss of response is to get on effective therapy and control the disease earlier in the disease course. That seems to be predictive. The other is to make sure that the therapy you're using has been optimized or is being monitored properly. So there are some steps patients can take to try to make sure that this doesn't happen as often, because obviously we don't want that to occur, and it's a big challenge when it does. The good news is we have more therapy options than ever before, and so sometimes making a switch is a good thing. So what do you do when the medicine stops working? What's the approach that our patients should know about?
Well, as we said earlier, even though you have symptoms, it doesn't necessarily mean that you have inflammation. So the first thing that we'll want to do is confirm that there is inflammation in the bowel. That might be with a marker in the stool or the blood, or we might go so far as performing a colonoscopy. We will probably rule out a bowel infection. That means submitting a stool specimen probably. If you're on a medication, a biologic in particular, where we know that you need a certain amount in your blood, a certain drug level, we may check that level and make sure it's in range. And if it isn't, we might actually boost the amount of the drug. We might change the dose if the drug level is too low, or shorten the frequency between doses, which is another way of changing the dose in a way. We might add another medication. Maybe in the short term, we might give you a course of steroids just to get the inflammation cooled off, and then hopefully you'll be okay again. But if we really think that you're no longer responding to the medication at all, we will probably switch you to another medication, either of a different type altogether or sometimes the same sort of medication.
Well, one of the challenges we know is that many patients are concerned about surgery, and we certainly appreciate that. Although a surgical decision might be obvious from the perspective of the healthcare provider, the gastroenterologist, or the surgeon, we recognize it's never an easy thing for a patient or their family. And so we wanted to talk briefly about what that means. Surgery is sometimes indicated for Crohn's, and as Dr. Sands mentioned earlier, it sometimes is the best way to get the disease under control, recognizing that very often Crohn's disease may be present and progressing before you're diagnosed, before you even have any symptoms. So by the time we start therapy, there's some scar tissue, or there may even be a partial bowel obstruction. And therefore, sometimes a limited resection of the bowel is the best treatment and the best way to get the disease under control. I don't mean to minimize this, except to say that one of the main advantages of doing so is that it's much easier to prevent the disease from coming back than to try to treat it when we're starting behind the game. And so we've learned an awful lot about how to monitor patients after surgery and how to use our treatments, many of the ones that you've heard about already, to prevent the disease from coming back. I often tell my patients that if they need a limited resection of their bowel for their Crohn's, our goal is that this should be the only surgery they ever have. And they feel well when it's over, and we move forward together. There are many different reasons to have surgery that aren't due to bowel obstruction, but are rare, like having bleeding, or quite rare would be to have a cancer of the bowel. That is not something that we worry as much about at all, and we certainly keep an eye out for. So there are different types of surgeries patients have. Of course, patients are always asking, are they going to need a permanent ileostomy or a stoma, where the bowel is brought up to the skin? That's uncommon. When it is done, it is often providing great relief to the patients, and we have many successful patients who are living very healthy lives with that anatomy. More commonly is where they remove a segment of bowel and sew the healthy tissue back together on the inside. The important thing to remember is that, as we've mentioned, the inflammation may come back in some patients, and you won't feel it right away. So you have to have a monitoring strategy. You'll feel great, but we want to keep you that way. And so any approach to surgery in Crohn's disease also includes a strategy for prevention and monitoring afterwards. A more common strategy of surgery, or at least use of our surgical colleagues, has been to do what's called an exam under anesthesia. Now what that means is that if there's perianal Crohn's disease, or some area that's too uncomfortable to be examined in the regular way in the office, they use anesthesia to make you comfortable, and then they can do a careful exam and either drain an abscess or help clarify a fistula tract. So the term exam under anesthesia is a type of surgery, but it's an outpatient procedure in most cases where you're cleaned up, you feel better when it's over, and then the medical therapy will work better. So there's some different ways that we work together with our surgeons. The main message we'd like you to understand is that talking about surgery is not meant to be the very last thing that we do. It should be partnered as part of all of our treatment strategies and all the medicines that you've heard about already today. So we're going to move through this because we have lots of great questions from our audience. And while I'm looking at the questions, I'm going to ask Dr. Sands to tell you a little bit about using checklists to manage your disease. There are a couple of checklists out there, and if you can just talk to them about that, I'm going to look at some of these great questions we have.
Sure. Yeah, checklists are a way of making sure that your doctor is doing everything that he or she can do to maintain your good health. And there are a variety of things that would include, and that might include vaccinations of various sorts to prevent infections while you're on medications. That might include cancer prevention things such as pap smears, skin screening for certain medications, colonoscopy if you are at risk for colon cancer, for example. And then your bone health has to be attended to. You shouldn't be smoking if you have Crohn's disease, because that makes the disease worse, and also checking for mood disorder, depression. So there are a checklist of things that should be covered, and there are such checklists available from the Crohn's and Colitis Foundation, also from the Cornerstones Foundation that Dr. Rubin directs. And checklists are used widely in all kinds of industries, such as the airline industry, to make sure nothing is missed. And that's exactly how we use them too.
And both of these checklists are available on the CME Outfitters website under the Patient Information tab. So you can get these as well as access to other great tools and previous educational programs. So Bruce, there's some great questions here. What an engaged audience we have, and I'm very grateful for these wonderful questions. Let me start with a couple questions just about inflammation. First of all, can calprotectin be used in people who have ileostomies?
That's a wonderful question. Calprotectin is potentially useful for patients with ileostomies because really calprotectin is measuring the presence of a certain kind of white cell called neutrophils, which are present whenever there's activity of Crohn's disease. So I think it could be used to monitor
And I've used it there.
ileostomy.
So that's
Yeah.
the stool marker for those out there who didn't remember all that.
Yeah.
Somebody else said CRP can be a marker of inflammation. That's the blood test
Yes.
anywhere in the body. So why do we use it for IBD if it's not going to tell us that it's just the IBD?
Well, it's true that the blood-based markers could be from an infection anywhere, it could be from inflammation anywhere in the body, but in the situation where we're reasonably sure that there is no other infection or inflammation, we can use it as some sort of indicator of the inflammation in the bowel, but it is imperfect because of that.
Why is the elemental diet only listed as an option for children? Doesn't it work in adults?
Well, in fact, there is evidence that not just elemental diet, but semi-elemental or more formula diets that are more palatable might actually work for adults as well. It's just that a lot of adults don't really want to take it, and as we said earlier, it works while you take it, and then when you stop taking it, if you don't otherwise modify your diet or your medications, you may be right back where you started from.
And there's obviously a lot of work going on now to try and understand more of the diet and the gut microbiome interactions and how we might use these. Maybe not always for induction, but maybe some modified version in the future for maintenance.
I think we will be.
And the key message for anyone who's considering more dietary approaches to their management is what we've said all along, which is monitoring. Make sure you're achieving your target of control. There's a question here just about how do you know that these new drugs are safe? This is a common question. We get asked this all the time in clinic. It's a completely reasonable thought that someone has. We are always hearing about a therapy that we thought we knew all about, and then there's something new. So how do we have this conversation with patients, and how can we reassure them?
Yeah, it's an excellent question and not a very easy one to answer because, of course, all drugs that go through the FDA approval process have had more than 1,000 patients who have gotten the medication and hundreds who have gotten it for a couple of years. And so there's a fair bit of evidence, but we don't always have 10,000 patients treated. But what we can do in many cases is these drugs may have been approved for other indications such as rheumatoid arthritis or psoriasis, and we would have some indications of the safety profile of the medication from those conditions as well, where many thousands, if not tens of thousands of patients would already have been treated.
And as you already mentioned, of course, our old-fashioned therapy, steroids, we know remains the most dangerous treatment we keep seeing in all the studies that have looked at it. I'll answer this question. Somebody asked about CBD products, so cannabis-related products for pain and inflammation for Crohn's. As I'm sure the audience knows, this is a therapy option that is available in many states now legally. And in fact, we recognize that cannabis may play a role in helping with bowel cramps or pain or nausea or appetite. But we also recognize that so far, there is not evidence that it controls the inflammation. The one study that's often quoted is from colleagues of ours in Israel, where it showed improvement in symptoms, but didn't show that the inflammation was under better control, and that's often misunderstood. So in my own practice, I can't speak for all my colleagues. I actually embrace it as a complementary therapy. It's not meant to substitute other treatments. And the general theme again tonight is we want to monitor and make sure we're achieving our targets. So I think that you can go to the Crohn's and Colitis Foundation website and read more about that. There's been some extensive new positions and discussions about that important topic. One more question I wanted you to address for us tonight is, how does Entyvio work? Is it actually suppressing the immune system? Would it affect the body's ability to fight infections in the gut? What can you teach us about that?
The best understanding of how Entyvio works is that it's actually blocking the white blood, certain populations of white blood cells that are targeted for the bowel and keeping them from entering the bowel. And those are potentially the troublemaker cells in the inflammation. So you can think of it as a roadblock. Basically, you're interfering with the zip code that targets the cells into the bowel. So in theory, while that would potentially increase the risk of bowel infections, you don't actually see that showing up very much in very large data sets. looking at the occurrence of infections, maybe just a slight increased risk, but not very much, which is a little surprising.
It's very interesting. And we certainly have seen enough patients on it now that we would have expected a stronger signal if that was going on.
Yeah.
I'll answer the last question and then I'm going to wrap, and I wish we could get to everyone's questions, but I think that this has been a very engaging program and we're grateful to all of you for sending your questions in. The question I'm going to answer is somebody asked about fecal transplantation. We're now actually calling it intestinal microbiota transfer or transplantation. The idea here is to take stool or a stool slurry from somebody who's healthy and to prepare it, screen it properly, and then to put it into the bowel of somebody who has a disease, in this case Crohn's disease. It is something that we know works for people who have an infection called Clostridioides difficile, but in Crohn's disease we haven't yet seen a signal that supports its use as a primary treatment. And in the guidelines they did not embrace this as a treatment with good evidence. There are many reasons this may be, and in ulcerative colitis we have a little more evidence, but one of the challenges is that we don't know what the perfect stool should be that we do this for, and we don't know enough about the safety yet for this. So you can look up DIY fecal transplants, but they're not recommended, and I would caution you against doing that. So with that, I want to just wrap. I want to specifically thank my partner here tonight, Dr. Bruce Sands from the Mount Sinai School of Medicine. I also want to thank the CME Outfitters crew for putting together this wonderful program, and I would refer you to their website and their Gastro Hub for Patients. So if you go to the website, navigate your way to the Gastro Hub for Patients for this program, as well as for some of the tools that we shared with you this evening, as well as for other programs. A special thank you to the patients who recorded audio clips for us and participated in the preparations for this program. And most of all, I want to thank all of you for joining us today for this program and all of your family members out there who are caring for you and who care about you. I hope that you found this helpful, and I hope the next time you see your care team, you can ask them some of the questions that came up tonight so that you'll all be on the same page. I wish you the very best.